Hi guys, we are going to discuss the NEET PG surgery questions of year 2024 and 2025. Let's start. So you can see the first question in the evaluation of squamous cell carcinoma of lip. What is the squamous cell carcinoma of lip? Which biopsy technique is considered most appropriate? Which biopsy technique is considered most appropriate for obtaining representative tissue sample for histopathological diagnosis? So whenever we are taking the biopsy, whenever we are taking the specimen, we have to include both tumor as adjacent normal tissue. So we have to include both the tumor as well as adjacent normal tissue whenever we are taking the biopsy. If you are taking biopsy from the center, what's the big problem? Yes, there are necrotic areas. So actually it's the edge biopsy or wedge biopsy. Important thing that you have to include the tumor as well as adjacent normal tissue. So one by one, let's discuss. It's the superficial shave biopsy of tumor surface. Obviously not. Second is complete excision of lesion. We are not going for complete excision of lesion. Third option is incisional. Third option, incisional biopsy including both tumor and adjacent normal tissue. So obviously this is correct. And D, punch biopsy limited to ulcerated surface. No, we are not going for punch biopsy. So what is the correct answer here? We are going for incisional biopsy including tumor as well as adjacent normal tissue. Now see the next question. Here you can notice that there is hyperpigmented area. Can you see this? Hyperpigmentation near medial malleolus, and you can see the sloping edges. There is pink granulation tissue in the floor, and here typical location just above medial malleolus, or it is located between medial malleolus and calf muscle. And what is the name of this area? This is known as Gators area or Gators region. So all of you know this is venous ulcer. What is this? This is venous ulcer. What is the typical location of arterial ulcer? Arterial ulcers are because of ischemia. It is because of arterial occlusion. What is the typical location of trophic ulcer? Have a look. So you can see here, this is venous ulcer. You can see this. This is venous ulcer, and the typical location, it is located between medial malleolus and calf muscle. This is known as Gators area or Gators region. You can see this is Gators area or Gators region, but it can be present over lateral malleolus also. Mostly it is located here. This is venous ulcer, also known as varicose ulcer. Here you can see arterial ulcer, and we discussed these are ischemic ulcer. It is caused by arterial occlusion. Typically, you can see that arterial ulcers are typically more common in the lower limb. And where exactly? Distal ends of limb where ischemia is common. So you can see that these ulcers are located over shin of tibia, over malleolus, under heel and over toe joints. Apart from this, there are other manifestations, other associations. Since there is ischemia, so what will happen? There are signs of ischemia, means there will be thin shiny skin because there is loss of fat. There will be lesser hair, and if you see the toe nails, those toe nails will be brittle, and sometimes because of ischemia there might be amputation of toes. So there might be evidence of amputation. Neuropathic ulcer, typically neuropathic ulcers are because of loss of sensation or patient is confined in one particular posture for long duration. So typically it is seen over bony prominences. So in this picture you can see it can occur over heel, malleolus, inner side of first metatarsal or toe joints, right? So the question was about varicose ulcer. Now you can see this one. Very easy question. Which of the following is a complication of total parenteral nutrition? Which of the following is a complication of total parenteral nutrition? So whenever you are giving TPN, in this we are giving 50% dextrose. And if you are giving dextrose, what's the big problem? There is hyperglycemia, one of the common complications. It's not hyperlipidemia, it's not hypertriglyceridemia, it's not hypoglycemia. It is hyperglycemia. So correct answer is option B. Next, a female presented with 1 × 1 centimeter thyroid swelling. What is the next best step? So any patient who is coming to you with thyroid swelling, what is the first investigation done? We are going for thyroid function test. And in thyroid function test, what are the investigations done? You know, T3, T4, TSH. So usually we are going for T3, T4, TSH, and you tell me out of these three which one is most informative. The most informative investigation is TSH because of its ultra sensitivity. Because of its ultra sensitivity, it's most informative because it will tell you about subclinical hypothyroidism, subclinical hyperthyroidism. If it's rising, it means patient is having hypothyroidism. If it's decreasing, it means patient is having hyperthyroidism. So it's not iodine 131. It's not only TSH. We have to combine TSH with T3, T4. Which one is better? It is TSH with T4, not T3, T4. So correct answer here, option C. You can see this question. In this colonoscopy image, you can notice that these are the areas where you can notice the pseudomembrane. So many pseudomembranes in the colon. Now read the question. If you read the question here, see this. A patient presented to OPD with recurrent diarrhea. Can you see this? Recurrent diarrhea, patient is having abdominal pain and patient is having foul smelling stool. Following findings were observed on colonoscopy. Now let's discuss one by one why it is not FAP, because in FAP there is no recurrent diarrhea. This kind of presentation is not there, and on colonoscopy what happens, multiple polyps will be there. How many polyps? You are going to find adenomatous polyps, and obviously typically the number is more than 100. What is the most common presentation of FAP? You know, patients are coming to you with bleeding PR. That's the most common symptom. In ulcerative colitis, there can be passage of stool, but it is mixed with blood. So recurrent diarrhea per se is not seen. Abdominal pain can be there. Loose stool passage of mucus and blood is there, but recurrent diarrhea is not there. And foul smelling stool, this finding is also not in favor of ulcerative colitis. Obviously, these findings are not seen in gastritis. It is typically seen in pseudomembranous colitis. So, recurrent diarrhea, abdominal pain, foul smelling stool, and you can see on colonoscopy presence of pseudomembrane. Can you see this? There is presence of pseudomembrane inside the colon, and typically this pseudomembranous colitis, it is caused by Clostridium difficile. There is another question which is asked in exam, that if you go for CCT, there is a typical sign, and what is the name of that typical sign on CCT? It is accordion sign, the musical instrument accordion. So typically in patients of pseudomembranous colitis on CCT, we are going to find accordion sign. So what's the name of sign? That is accordion sign. Now you can see the next question. Very, very easy. What is the appropriate definitive management for a patient presented with constant chest pain and radiological findings suggestive of Stanford type A aortic dissection? What is Stanford type A aortic dissection? In which ascending aorta is involved. And in these cases, you have to go for surgical management. Why? Because if you are going for medical management, it is having high mortality. So let's first discuss what is the Stanford type A, type B, and what is DeBakey. For aortic dissection, first see the DeBakey classification type 1. In type 1, this is responsible for 60% cases. So can you see this is DeBakey type 1. Here you can notice that there is intimal tear in ascending aorta. You can notice that here. Where is the intimal tear? In this case, the intimal tear is here in the ascending aorta. Apart from that, it is extending to descending aorta. Can you see this? So it starts from ascending aorta and it's involving descending aorta. What about type 2? Type 2 is limited to ascending aorta. You can see this in this picture. It is limited to ascending aorta. What about type 3? In type 3, there is intimal tear in descending aorta. You can see here with distal propagation. You can see the intimal tear. So in this case, you can notice the intimal tear in descending aorta with distal propagation. So this is DeBakey 1, 2, 3. You know that DeBakey 1 and DeBakey 2, it is included in Stanford A. So what is Stanford A? It's proximal. What is Stanford B? It's distal. And if you see Stanford A, here there is involvement of, at least involvement of ascending aorta. So whenever patient is having aortic dissection, Stanford A, you have to go for surgical management, because only if you are going for medical management, it is having high mortality rate. Clear? So two questions which are asked in exam, they ask you the DeBakey classification, Stanford classification. Which one is most common? Obviously Stanford A, DeBakey type 1. So now see the question again. If you see the question again, read it. Patient presented with constant chest pain. What else? There is radiological findings suggestive of Stanford A. Obviously, we will go for surgical management. Any kind of medical management is associated with high mortality. So medical management is associated with high mortality, and that's why we are going for surgical management. Clear? So correct answer is A. Now you can see the next question, very easy. Identify the procedure commonly performed in patients with recurrent GERD. All of you have seen that this kind of question, image-based question, was asked multiple times. What is being done? In this picture, you can see that we are going to placate the fundus around LES, around 360 degree of LES. So here, this is actually 360 degree. Can you see this? So this is fundoplication, and how much it is 360 degree fundoplication, and this 360 degree fundoplication is also known as Nissen's fundoplication. So what's the correct answer here? You can see the correct answer here. The correct answer, it is 360 degree Nissen's fundoplication. It's not gastrectomy, obviously it's not gastrectomy. It's not the banding, it's not 270 degree. What is the name of 270 degree? If it is posterior, it is known as toupee, and if it is anterior, that is known as Belsey Mark IV. So let's discuss the fundoplication. First, you know what is 90 degree anterior. The 90 degree anterior, that is known as Watson. Name of fundoplication? It is Watson. What is door? You can see in this picture, door that is 180 degree anterior. Can you see toupee? You are going from behind. So this is actually 270 degree posterior. What is 270 degree anterior? That is Belsey Mark IV. Remember, 270 degree anterior, that is Belsey Mark IV. So what's Belsey Mark IV? So this is Belsey. This is Belsey Mark IV. And this is 270 degree anterior. And worldwide most commonly performed fundoplication, and that's Nissen's. You can see this is 360 degree. So this is 360 degree fundoplication, and you know this is the gold standard, or I should say the treatment of choice for GERD. Nissen's fundoplication, 360 degree, and we are going to perform it laparoscopically. So it's laparoscopic Nissen's fundoplication. Next, very easy question. See, a patient presented with what? Growth over the penis, right? It is classified as T3. There is no enlarged inguinal lymph nodes detected. What is the best method of management? In these cases, we have to go for penectomy. Apart from penectomy, what's the problem? Because in carcinoma penis, the lymph nodes are enlarged, sometimes because of sepsis and sometimes because of metastasis. What happens? You should go for superficial inguinal lymph node dissection, and that is also known as modified inguinal lymph node dissection. So see the options. You are going only for penectomy? No. Orchidectomy? Not required. Penectomy with deep inguinal lymph node dissection? Not required. We are going for penectomy with superficial or modified inguinal lymph node dissection. Correct answer is option C. There is another question. They ask you that suppose patient is having carcinoma penis, in which case circumcision is sufficient. So if there is only involvement of prepuce, only there is involvement of prepuce, in that case circumcision is sufficient. Whenever malignancy is involving proximal part, in that case we can go for partial penectomy. If it is involving distal parts, imagine it is involving distal part. In distal part we are going for total penectomy, and when you perform total penectomy, in that case you go for perineal urethrostomy. You have to make the urethral opening in the perineum. तो इसका नाम क्या होगा? This is known as total penectomy plus perineal urethrostomy. So here what's the correct answer? Correct answer is option C. Now see the next question. Very easy question. 20 years old. You can see 20 years old, chronic alcoholic, presents with severe hematemesis. Can you tell me the cause? What's the cause of severe hematemesis in chronic alcoholic patient? Obviously, in majority of cases, it's because of varices. Ultrasound shows distension of portal vein. Distension means obviously patient must be having cirrhosis. There is portal hypertension. What happens? There is compression of portal vein branches, and that's why there is distension of portal vein. Liver appears hyperechoic. Pantoprazole, whenever any patient is coming to us with upper GI bleeding, we have to start PPI, right? Has been administered. What is the next appropriate step? Any patient who is coming to you with upper GI bleeding, especially variceal bleeding, these patients are in the state of shock. And since patients are in the state of shock, we have to give IV fluids. We have to resuscitate the patient. So see the options. Initiate a course of broad spectrum antibiotics, not immediately. We are not going to start it immediately. Order a liver biopsy, not required at this point of time. Administer intravenous fluid and electrolyte replacement. Obviously, perform an endoscopy. No, first what we have to do? First we have to resuscitate. After resuscitating, because of bleeding, the blood is collected into the stomach. And since blood is collected into the stomach, what happens? You have to control the bleeding. How you control the bleeding? By pharmacotherapy. And what are the drugs given? To control the bleeding, we are giving octreotide. And second option, we are giving terlipressin plus nitrates. Pharma book says that give terlipressin plus nitrates, and Bible of Hepatobiliary Surgery, Bloomgard, and surgery book says give octreotide. So octreotide is first line. When bleeding is controlled, we perform the gastric lavage because stomach is full of blood. You clear the stomach and then you perform the endoscopy. So first administer the fluid, resuscitate, control the bleeding, do the lavage, and then perform endoscopy. And after endoscopy, the treatment of choice is endoscopic varicose ligation. Second option, we have endoscopic sclerotherapy. So here, what's the correct answer? Tell me. C. Next question, easiest question, and you know in each and every paper you will find this question. मैं आपको बता दूं हर साल आपको EDH stage में at least one question is asked. Every year in each and every paper you are going to find EDH and SDH. This year also in NEETPG you are going to find this question. So patient was brought to the emergency department after history of fall and head injury. On this CT you can notice that patient is having crescent shaped hyperdense lesion or concavo-convex hyperdense lesion. This is STH. So here there is concavo-convex, you can see concavo-convex hyperdense lesion, that is also known as crescent shaped. So that is also known as crescent shaped hyperdense lesion. What kind of hyperdense lesion is seen in EDH? You can see here. Here, these two are very, very important. In this image you can notice here. This is biconvex, also known as lemon-shaped, idli-shaped hyperdense lesion. So this is biconvex. Biconvex, here you can see crescent-shaped or concavo-convex or banana-shaped. So this is crescent-shaped. This is crescent-shaped hyperdense lesion. And all of you know that EDH is because of injury of middle meningeal artery. Which division? Anterior division. So it is because of middle meningeal artery. Which division? A means anterior division. It is because of trauma to weakest part of skull. And you know what is the weakest part of skull? That is steryon. So even a trivial trauma can lead to this injury. It's the division. Which one? Anterior division. There is one interval which is positive, lucid interval. What's the name? It is lucid interval which is positive. What is lucid interval? One episode of consciousness between two episodes of unconsciousness, and obviously investigation of choice in both is NCCT. Here, this is EDH, extradural or epidural hematoma, in which the blood is collected between skull and dura, and this is subdural, means beneath dura. So where exactly? Between dura and arachnoid. Here, it is caused by significant trauma, especially injury of cortical veins. And what is the other name of cortical veins? You already know. Cortical veins are also known as bridging veins. Here also, we are going to make the diagnosis by NCCT. If small hematoma is there, you can drain it by burr hole. But if large hematoma is there, in that case, we have to go for craniotomy. So two options we have. First, burr hole, and second option we have craniotomy. So it's burr hole, and the second option we have craniotomy. Clear? Now see the next question. Very easy. How does the graft get nutrition on day 3? See, whenever you apply any skin graft on a vascularized recipient bed, this phenomena is known as graft take. This acceptance is known as graft take. Now what happens? For the first 48 hours, graft is going to receive the nutrition by diffusion, that is known as imbibition. So imbibition occurs for the first 48 hours. First 48 hours. After that, there is inosculation. It is complete by 4 to 5 days. So for 4 to 5 days, there is inosculation. What happens in inosculation? Capillaries are aligned together. And after 5 days, there is established arterial supply and venous drainage. That is known as revascularization. So you know, it is after 5 days. So here, by 4 to 5 days, what is complete? Inosculation. For the first 48 hours, it is imbibition. So can you see day 3? In day 3, what's occurring? Tell me. Inosculation. This is very important. Let's discuss what is graft take. we discussed acceptance of graft. By vascularized recipient bed, there is imbibition. So here, graft survives for the first 48 hours. So up to 48 hours, and here it receives nutrition via diffusion. So there is free absorption of nutrition via diffusion. We discussed in inosculation, capillaries are aligned together and it is complete by 4 to 5 days. After 5 days, arterial supply and venous drainage is well established, that is revascularization. This is very, very important. Now read this question. Identify the procedure done in this male patient. Can you see the genitalia of male patient? You can't see the genitalia in this patient. Can you see this? You can't see the genitalia. In this patient, you can't see the genitalia. So here total penectomy is done. And how this patient will be passing the urine? Can you see here? Here, can you see this catheter? So here, what you are creating in this picture, you have to make perineal urethrostomy. So there is perineal urethrostomy. The urethral opening should be done in perineum. So this is total penectomy with perineal urethrostomy, and typically it is done in which patients, tell me? So typically it is done in which patients? Typically it is done in the patients of carcinoma penis. So what is the name of this procedure? Total penectomy plus perineal urethrostomy. Now see the options. Orchidectomy, obviously it's not orchidectomy, it's not partial penectomy or hernioplasty, it's total penectomy plus perineal urethrostomy. Correct answer is option B. Now you can see the next question. Very easy. What you can see in this picture? In this picture you can see that patient is having DJ stent, and how you insert DJ means double J. You can see this is DJ, this is also J, this is also J. So DJ stent, how you insert DJ stent? First you perform cystoscopy. You visualize the bladder and then via ureteroscopy, you are going to insert the DJ stent, right? So see, what instrument is used to insert this tube? Nephroscope? Obviously not. Ureteroscope? Only ureteroscope? No. Endoscope? No. It's the cystourethroskop. So for insertion, we need cystourethroskop. What's the name of this stent? You know, this is DJ stent. So we need cystourethroskop. Okay. Now see the next question. Very easy question. This was asked multiple times. There is a term known as NPWT. Can you tell me what is this NPWT? It is negative pressure wound therapy, or also known as vacuum assisted closure. What we do? We apply a sealed dressing and via tubings we are going to create negative pressure. How much negative pressure? Minus 125 mmHg. So you create vacuum. What is the advantage? Tell me. Any patient who is having chronic wound, what's the problem? It's not healing. If you apply suction, if you apply vacuum or negative pressure, it will suck blood over the surface, since it is going to it is going to increase the blood supply to that area. It promotes faster healing. So that's why for chronic wounds, we are using vacuum assisted closure or negative pressure wound therapy. And you know how much pressure we are going to apply? Remember this, minus 125. Two pressures you have to remember. One is minus 125. Negative pressure wound therapy, and whenever a patient is having compartment syndrome, the patients who are having compartment syndrome, how much should be the pressure in the compartment? More than 30 mmHg. So in compartment syndrome, it should be more than 30 mmHg. Here it should be more than minus 125. So it's minus 125 mmHg in negative pressure wound therapy, that is also known as vacuum assisted closure. See the next one. See this picture first. What you can see in this picture? You can notice that there is testicular torsion. Can you see the color? Color is almost black, bluish or black. Now read the question. A 12 years old child. You can see a 12 years old child present to OPD with complaints of scrotal pain. Why this patient was having scrotal pain? Tell me. History of trauma 6 hours prior. Upon surgical exploration, findings suggest significant damage. You can see the damage. There is torsion and there is gangrene. What is the most likely diagnosis? First option, testicular torsion with gangrene. Correct. Second option, torsion of testicular appendages with gangrene. No, there is torsion of testes. You can see. Strangulated inguinal hernia. No, it's not related to trauma. Testicular hematoma. No, it's not hematoma. So correct answer is option B. Now see this question. A patient presented to OPD outpatient department with ulcerated breast tumor. What kind of tumor? There is ulceration, ulcerated breast tumor and liver metastasis. So can you tell me the stage? Any patient who is having metastasis, obviously it is stage 4. Stage 4. And this patient is having what kind of tumor? Ulcerated breast tumor. What is the appropriate management? First, 2-3 things you have to remember. That in metastasis, surgery is not done for curative intent in breast cancer. I am repeating. In metastasis, surgery is not done for curative intent. Clear? Now the problem, the patient is having ulcerated lesion. Let me tell you, any patient who is having ulceration, some kind of fungating lesion, foul smelling discharge, open wound over the breast cancer. In these cases, what we do actually, we are going for toilet mastectomy. What is toilet mastectomy? Here we are going for simple or total mastectomy. Why? So that, only for palliation, so that its patient is having a good quality of life, we can manage it properly. So it's not done for curative intent, it's done for hygiene, it's done for palliation. So in this case, we are just going for toilet mastectomy. What should be done? We are going for toilet mastectomy, and what is done here? Actually, we are doing simple mastectomy. So what's the correct answer here? A. MRM not required, radical mastectomy not required, neoadjuvant chemotherapy followed by surgery, no. Here we are doing surgery only for palliation and for better hygiene. So correct answer is option A. Let me discuss what is our protocol. Any patient who is having metastatic breast cancer, surgery is not performed with curative intent, we discussed. Suppose patient is having ulceration, fungating lesion, foul smelling bleeding or painful breast tumor. In these cases, we are doing localized surgery only for palliation and hygiene, and this is known as toilet mastectomy. We discussed what is this actually? It is just the simple or total mastectomy. What we do here, removal of nipple, areola skin, breast tissue, breast mass. Clear? Next question, very easy. You can see this picture. In this picture, you can see that there is a cystic lesion inside the kidney. Can you see this kidney? Clear? So you can see this. In the right kidney, you can see there is cystic lesion. Now read it. A 62 years old female undergoes CCT, contrast enhanced CT, for unrelated mild abdominal discomfort. Scan reveals solitary 4 cm round, dark, fluid filled lesion in the right kidney. The lesion does not change in appearance or become brighter after administration of intravenous contrast. It means it's not hypervascular. Based on these findings, what is the most likely diagnosis? Obviously, it's typical case of renal cyst. It's renal cyst. It's not renal tumor. In ADPKD, what happens in both kidneys, multiple cysts are there. So it's not ADPKD and it is not hydatid cyst. So what is the correct answer? Because clear fluid is there. So correct answer is option A. Patient is having renal cyst. Next question, very easy. Here you can see the hydatid cyst. And in this picture, you can see this detached membrane which is floating inside. So this is known as floating membrane or undulating membrane, and this is known as water lily, also known as water snake sign. According to Gharbee's classification, type 1, simple fluid collection. Type 2, floating membrane or undulating membrane, that is also known as water lily sign. Type 3, in that case what happens? It is, tell me, multiseptated or multiloculated. Type 4, there is complex heterogeneous mass because solid areas are there, cystic areas are there. And type 5, that is calcified. So you can see here, since you can notice that this patient is having water lily sign, and water lily sign is typically seen in type 2 according to Gharbee's classification. Let's discuss quickly. It's very, very important. You know what is type 1? You can notice simple fluid collection. Type 2, you can see this is water lily or water snake sign. You can see the floating membrane or undulating membrane. Type 3, multiseptated or multiloculated, that is known as honeycombing. And type 4, here, complex heterogeneous mass. And what is type 5? You can see here, calcified cyst. And you know, calcified cyst means dead cyst. So this is very, very important. Gharbee's classification, it is based on which investigation? Ultrasound. Remember, WHO classification is different. That starts from CE1, CE2, and this starts from 1, 2, 3, 4, 5. Next question. Endoscopic image shows following findings. What's the diagnosis? Tell me. On this endoscopy, you can notice that these are dilated collaterals in the esophagus, right? And what are these dilated collaterals? These are venous collaterals. Obviously, these are esophageal varices. So, what's the diagnosis? You can see it's not Barrett's. What happens in Barrett's? There is tongue-like projection, red velvety mucosa is there. It's not gastric erosion. It's not chronic GERD. This is esophageal varices. Tell me, what's the treatment of choice? For esophageal varices, we are going for endoscopic varicose ligation, that is preferred over endoscopic sclerotherapy. See this question. A patient presented with umbilical hernia was previously reducible, but now became irreducible. Which of the following is most appropriate management option? Now see the image. Hernia is irreducible. Second thing, you can see the color change over the umbilicus. Can you see the redness? And here, can you see the sign of blackish discoloration? It means this is not obstructed hernia, this is strangulated. What is obstructed? What is strangulated? Obstructed hernia means there is obstruction with preserved vascular supply. Strangulated, obstruction with impaired vascular supply. And whenever you can see the skin changes or discoloration in skin, it is highly suggestive of what? Strangulation. Clear? Now see the management. In this case, obviously we have to go for surgery. So what you do, this area should be excised. So what you do here, you are going for umbilical excision. Yes. Are you going for mesh hernioplasty? No. Whenever there is obstructed or strangulated hernia, we are not using the mesh. Mesh is not used. Mesh is not used. There is no role of conservative management. So here what we are going for? We are going for umbilical excision. Now see the next question. Very easy. If you see this picture, can you see the leaf-like appearance? This is one of the typical images asked. Two image-based questions which are asked in integrated fashion with pathology in breast. One is fibroadenoma and the second is this one, cystosarcoma phyllodes. Read the question. Read it. A 40-year-old female, see the problem? There is irregular 5 into 6 centimeter mass in the right breast. Histopathological examination reveals leaf-like appearance. What's the diagnosis? Phyllodes tumor. Another finding in phyllodes tumor, it is also known as cystosarcoma phyllodes. Cystosarcoma phyllodes. What is the special feature? Guys, that affected breast is massively enlarged. It behaves like, name is cystosarcoma, so behaves like sarcoma. What are the features of sarcoma? In sarcoma, there is exclusively hematogenous spread, no lymphatic spread. So in this tumor also, no lymphatic spread, exclusively hematogenous spread. Just like sarcoma, the most common site of metastasis is lungs. Investigation of choice is biopsy. Treatment, just simple mastectomy because lymph node is not involved. Remember, 3 things are not involved in cystosarcoma phyllodes. What? Breast skin, nipple and chest wall, and that's why there is no skin fixity. It is mobile over chest wall, no nipple retraction, no deviation, no ulceration. So this is cystosarcoma phyllodes. Correct answer is option A. Option A. See the next one. Very easy question. It was asked multiple times. What is this? Skin graft. What kind of skin graft have you seen? It is meshed skin graft. What is this meshed skin graft? Whenever we don't have adequate amount of graft and we have to cover huge surface area, we are going for meshing. It is a type of split thickness skin graft. So this is meshed skin graft. What's the name? Meshed skin graft. It's a type of STSG, and STSG, that is split thickness skin graft, also known as Thiersch. It is also known as Thiersch. What is full thickness skin graft? That is known as Wolff's. It is known as Wolff's. In split thickness, we are taking epidermis plus part of dermis. We are taking epidermis plus part of dermis. In full thickness, we are taking epidermis plus full thickness of dermis. What is the advantage of split thickness skin graft? Since you are taking only part of dermis, here repeated grafts will be taken. Donor site can be used multiple times. It heals spontaneously. But in full thickness skin graft, donor site develops permanent defect. That's why repeated grafts cannot be taken. And one of the most common donor site of split thickness skin graft? Tell me, inner aspect of thigh. So what is the donor aspect? Donor site, that is inner aspect of thigh. So these are the important questions. And what happens in split thickness skin graft, the disadvantage, it is going to contract on maturation. And this contraction is known as secondary contraction. So it is going to contract on maturation. So how to remember? S is more common in S. What is S? Secondary contraction is more common in ST-SG. So correct answer is A. Now see this question. A Jeep driver, first hint, Jeep driver, presented with pain in the gluteal region. Where is the pain? In the gluteal region along with swelling, right? What is the most likely diagnosis? Now see the picture. If you see this picture in the gluteal region, what happens? You are going to notice this opening. What is this opening? Yes, it's a sinus. You can see here, there is evidence of abscess also. So two things, there is sinus and abscess. The patient is having pilonidal sinus. Whenever it is blocked, what happens? Patient is having abscess. And in this case, you have to go for IND and you have to give antibiotics. Now the problem, patient is having pilonidal sinus. Why Jeep driver? You know, it is common in Jeep drivers of army. And this is known as what? Jeep's disease. Exclusively seen in males. What kind of males? Hairy males. This is acquired condition. So this is pilonidal sinus. What are the special features about pilonidal sinus which are asked in exam? First, common in Jeep drivers. That's why it is known as Jeep's disease. Jeep's disease, it is seen in hairy males. And whenever there is pilonidal sinus, what happens? There is a small opening on the surface, but inside there is a cyst. In that cyst, there is collection of dead hair. What you have to do? Actually, you have to excise the whole cyst. And if you excise the whole cyst, there is a defect. When there is a defect, you have to close it. You have to cover it. And how you cover it? Apart from excision, you have to cover it with flap. Remember the names of flaps used in pilonidal sinus. Name, Limburg flap. So this is Limburg's flap. There is another name which you have to remember, name Caridaki's. So Limburg's flap, this is known as Caridaki's flap. And you know Limburg's flap, it's a type of rhomboid flap. This was the question in INI-CET. Name rhomboid. This is known as rhomboid flap, and there is a procedure which includes both. It includes both the excision as well as flap closure. And what's the name of this procedure? This is known as Bascom procedure. So name of this procedure, this is known as Bascom procedure. Name, this is Bascom procedure. So what is the correct answer? Pilonidal sinus. It's not fistula in ano, because in fistula in ano, what happens? There is no relation with Jeep driver. And what happens? Unresolved abscess is going to rupture outside. There will be external opening. It's not fissure, it's not gluteal abscess. So correct answer is option A. Now see the next question. Very easy. Just see this MCU. Can you see this MCU? Micturating cystourethrogram. You can see the bladder. Which part of urethra is dilated? Posterior urethra. And then abruptly you are going to notice that what? Here is the stricture. Either stricture or obstruction, some kind of obstruction. So only posterior part of urethra is visible. So what is the problem? It's a child. And if a child is having dilated posterior urethra, there must be some kind of obstruction. And where? In the posterior urethra. Around, prostatic urethra. So what is this actually? It's valve. So what's the problem? You can see this patient is actually having a valve. Read the question. Child presents to OPD. Radiological images given below, most appropriate management. So what's the problem here? See the picture. This is your patient. This is the bladder. This is the urethra. Inside urethra, this kind of valve is there. Yes, valve. That's why what will happen? This part of urethra will be dilated. What is this valve? Posterior urethral valve. What you have to do? Yes, first, since it leads to back pressure changes in both kidney, first you insert infant feeding tube. And when you insert infant feeding tube, creatinine becomes normal. After that, you go inside the urethra and perform endoscopic fulguration of valve. So what we do here? We are going inside the urethra and we are going for fulguration. So we do endoscopic fulguration of valve. This is posterior urethral valve. What is done? It is endoscopic ablation or fulguration. Dilatation is not required because there is presence of valve. You have to fulgurate these valves. Dilatation is not required. Conservative management, no, it's not having any role. Correct answer is option A. Other questions which are asked, see, this is the picture. So in this picture, you can notice that here is the valve. That's why this part of urethra is dilated, and you can see bladder is distended. if you are going to perform ultrasound during pregnancy, this kind of appearance is seen. And can you tell me what is the name of this appearance? Tell me. This is known as keyhole sign. What's the name? One of the commonly asked question in posterior urethral valve, keyhole. So this is keyhole sign. Where exactly this valve is located? In the posterior urethra, just distal, or it's located at verumontanum. So just distal or at verumontanum. Okay. And how to manage? Obviously, we put infant feeding tube so that creatinine becomes normal, obstruction is relieved, general condition of patient is going to improve, and then we go inside and we perform endoscopic fulguration of valve. Clear? Now see the next question. Very easy. मैं आपको बता रहा हूँ 100% chances है question आएगा. Similar question is expected. You can see the patient is having pressure sore or pressure ulcer over sacrum. What you can see? You can see the muscle, you can see the bone. Any pressure ulcer or sore where muscle is visible, or you can see the bone, obviously it is stage 4. So what is this? This is stage 4. Let me tell you the clue. It's very easy actually. There is no difference between Burns grading or Burns classification and staging of pressure ulcer. You know what is first degree burn? In first degree burn, there is involvement of epidermis. That's why it is known as epidermal burn. And in stage 1 pressure ulcer, see, in stage 1 pressure ulcer, there is involvement of epidermis. So there is just the erythema. What happens in second degree burn? It is partial thickness burn because there is involvement of epidermis plus dermis. What is stage 2? That was partial thickness burn. This is partial thickness skin loss involving epidermis plus dermis. What is third degree burn? Epidermis plus dermis plus subcutaneous tissue or fat. It is known as full thickness burn. And whenever there is full thickness skin loss involving epidermis plus dermis plus subcutaneous tissue, that is stage 3. What was fourth degree burn? Apart from skin, there is involvement of underlying structures like muscle or bone. And what is stage 4? Apart from skin, whenever there is involvement of underlying muscle or bone. Easy? So let me tell you, actually there is no difference in burn classification and pressure ulcer. Anywhere you can see the bone, you can see the muscle, it is stage 4. So I'm telling you 100% chances are there. We are going to get a question from this topic. You can see what is stage 1? In stage 1, erythema. In 1 and 2, epidermis plus dermis. In 3, epidermis plus dermis plus subcutaneous tissue. And in 4, apart from skin, there is involvement of muscle and bone. Now see the picture. You can see this picture here. There is involvement of epidermis plus dermis. This is stage 2. You can see this one. In this case, apart from epidermis and dermis, there is involvement of subcutaneous tissue. This is full thickness skin loss. That is stage 3. And here the same picture is there. You can see the muscle or bone. So this is full thickness skin loss with involvement of muscle or bone. When the muscle is visible, bone is visible, it is stage 4. मैं आपको question बता देता हूँ. What is expected? We are expecting sacrum. Exposed sacrum in a person who was immobilized for long duration because of paraplegia or quadriplegia, and obviously what's the stage? 4, right? Now see the next question. Very easy question. Which of the following is most important indication? There are multiple indication, but here most important indication for adjuvant radiotherapy in oral malignancy after MRND, modified radical neck dissection. Right? So, will you give radiotherapy or not? Here, if there is extra nodal extension. Whenever there is extra nodal extension, in that case, you have to give radiotherapy. Multiple lymph node metastasis, not that important. Indication, T3 tumor, not required. Always closed margin, no. Whenever positive margin is there, in that case also we give radiotherapy, but most important indication is extra nodal extension. Now, see the next one. Very easy. See this crystal first. Can you see the shape? If you see the shape, the crystal is like this, hexagonal or just like benzene. Can you tell me which crystals are hexagonal or just like benzene? Benzene shaped or hexagonal crystals? Okay. Read the question. Young patient presents to OPD and he is having recurrent colicky abdominal pain. Urine examination reveals presence of RBCs and this crystal. So obviously this patient is having stone. What kind of stone? Tell me. Cystine. Why it's not oxalate stone? Because there are two types of oxalate: calcium oxalate dihydrate, calcium oxalate monohydrate. In dihydrate stone, what is the shape? Shape is like this, envelope shape in dihydrate. In monohydrate, it's like this. It's just like hourglass or dumbbell shaped. So this is monohydrate. That is hourglass or dumbbell shaped. This is dihydrate. And you know, in dihydrate, what kind of crystal is there? Bipyramidal or envelope shaped. Right? There is another crystal in struvite or triple phosphate or staghorn calculi. There is coffin lid crystal. Coffin lid. So these are the four crystals which are asked. I am repeating. Dihydrate, envelope shaped or bipyramidal. Monohydrate, hourglass or hourglass or dumbbell shaped. Cystine, you told me just now, hexagonal or benzene shaped, and in staghorn calculi, triple phosphate, struvite, there is coffin lid crystal. So here correct answer is option D. Now see this question, it is very important, and almost every year in at least one exam you are going to get it. You can see here there is pure orange. Apart from pure orange, you can see the redness. This redness is involving more than 1/3 of breast skin, and whenever there is evidence of redness, erythema or inflammatory changes in the breast involving more than 33% of breast or more than 1/3, this is known as inflammatory breast cancer. And if it is inflammatory breast cancer, what is the stage for IBC? For inflammatory breast cancer, the stage is T4D. If it's only pure orange, if there is only pure orange, then it is T4B. So you can see the picture. 43 years old female presents to OPD with changes in breast and a lump as given below. This is T4D because you can see the inflammatory signs. This is inflammatory breast cancer. So two stages we have to remember. T4B, that is pure orange. This is pure orange, and T4D, that is inflammatory breast cancer. What is T1? Size, you can see here T1, the size of tumor up to 2 centimeter. You can see T2, more than 2 to 5 centimeter. You can see T3, that is more than 5 centimeter. After that, you can see T4A. In T4A, there is extension to chest wall, and you know that chest wall is formed by ribs, intercostal muscles, serratus anterior. So T4A, whenever there is extension to chest wall, याद कैसे करना है? A means अंदर, तो breast के अंदर है chest wall. T4B, B मतलब बाहर, breast के बाहर. So involvement of breast skin. And what are the changes included? Tell me. Ulceration, edema, including pure orange, and satellite nodules. So edema including pure orange, satellite nodules. You know what is T4C when it's both A and B. So T4A plus T4B, and the most important T4D. What is T4D? That is inflammatory breast cancer. मैं फिर से बता रहा हूँ 100% ये question आएगा. Which question we are expecting? Either T4B, that is pure orange, or T4D, that is inflammatory breast cancer. Now see the next one. Very easy. Very easy. This question was asked for the first time. In this picture, what you can see? This is external anal sphincter. This is internal anal sphincter. And you can see the tract is passing between the sphincter. When the tract is passing between, it is known as intersphincteric. And what is intersphincteric? Tell me. This is type 1. So this is actually fistula in ano according to Park's classification. What is type 1? Type 1, that is intersphincteric. Type 2, transsphincteric. Type 3, suprasphincteric. Type 4, extrasphincteric. And the most common type, intersphincteric. So what is the correct answer here? It is intersphincteric. We are expecting similar questions in the future. Have a look. So you can see first, type 1. This is intersphincteric because it is passing between the sphincters. You can see it is crossing both sphincters. This is known as trans. So what's the name? Transsphincteric. It is going above the sphincter. What's the name? Suprasphincteric. And here outside the sphincter, extrasphincteric. So this is Park's classification. आपकी PSM की book का नाम भी है Park's. How to remember? Most common type is 1. After that type 2. After that type 3. After that type 4. How to remember? Mnemonic is it's extra. Can you see? ITS, it's extra. Intersphincteric, transsphincteric, suprasphincteric, extrasphincteric. So we are expecting this question. Okay. Now see the next question. Very easy. See this patient. The patient is having burns. And can you see it's 3rd degree burn? And what happened? You can see the eschar also, it's in the lower limb. And you can notice that there is circumferential eschar. Whenever there is circumferential eschar, there is high risk of compartment syndrome. And to prevent compartment syndrome, you perform escharotomy. So can you see here what you do? You can give this kind of incision over the eschar. You can see this is escharotomy. Read the question. A 30 years old female brought to emergency medical room after fire on examination of lower limb, full thickness burn, 3rd degree, deep partial thickness burn, okay, involving it circumferentially. Procedure was performed given below. So obviously it is escharotomy. It's not the debridement. What is debridement? Debridement में हम लोग क्या करते बताइए? Whenever there is necrosed skin, you have to debride it. You have to excise that part. Excised to healthy tissue and fascia, that is fasciotomy. Early skin grafting, it is not skin grafting, it is escharotomy. Correct answer is option A. Now see this question number 31. A 25 years old patient had road traffic accident. Patient was having road traffic accident. Initially he was conscious but later became unconscious and subsequently died. On post-mortem examination, multiple petechial hemorrhages were seen in corpus callosum. What is the probable diagnosis? This kind of presentation is typically seen in diffuse axonal injury, in which in majority of cases when the patients are brought to your emergency, they are in the vegetative state. And if you are going for NCCT, actually NCCT is normal. That's the big problem. So here the diagnosis is made on MRI. This is the typical picture of diffuse axonal injury. So this is diffuse axonal injury in which there is widespread axonal damage, and that's why it is having very poor prognosis. I'm telling you 3-4 questions which are asked every year in each and every exam. First question, elderly male, history of fall in the bathroom, there is head injury. What happens? STH. Subdural hematoma. On NCCT, there is concavo-convex hyperdense lesion. First question. Elderly female, history of fall in the bathroom, and there is fracture neck of femur. After that, immobilization was done, hemiarthroplasty was done. For 3 months, she was immobilized and later died. Why? She developed DVT and she died because of pulmonary embolism. Another question, 20 to 25 years old male, history of road traffic accident because he was riding the bike. At the time of presentation, he was having multiple long bone fractures. Patient appears to be stable, but within 24 to 48 hours, there was deterioration. Patient was having clouding of consciousness, there was respiratory distress, there was petechis or rashes over chest, over axilla, petechi in the conjunctiva, retina, and what happens? There was passage of fat globules in the urine. What? Fat embolism or fat embolism syndrome. And the fourth is this one, road traffic accident, young male, bike, high speed. Whenever patient is brought to your emergency, patient is in the vegetative state, NCCT was normal, later patient is going to die, and on MRI these kind of changes are seen. So this is diffuse axonal injury. I'm telling you 4 questions. 1, SDH. Second, DVT with pulmonary embolism. Third, fat embolism. And fourth, diffuse axonal injury. These are expected in exam. Fifth question which we are expecting, that is tension pneumothorax. Typically, history of road traffic accident, patient is having respiratory distress, there is dyspnea, tachypnea, pulse rate is high, patient is having low BP, systolic blood pressure is 90, and what happens on examination? Absent breath sounds, there is hyperresonance. What you do? Put a wide bow needle. Treatment of choice is ICD insertion. So these are the potential questions which we are expecting in upcoming exam. So guys, here what's the correct answer? Option B. Okay. Now see the next question. Very easy question. Patient arrives at the emergency room with penetrating injury and low BP. Any patient who is having penetrating trauma and patient is unstable, patient is having low BP, unstable. In this case, what happens? Just after resuscitation, take the patient for laparotomy. So here we have to go for emergency laparotomy. CT scan, patient is unstable, we don't have time. DPL not required in penetrating trauma. DPL is done in blunt trauma. Ultrasound, it is done in blunt trauma, not required here. So we are going for emergency laparotomy. Correct answer is option A. Now see the next question. Very easy. Neonate Diagnosed with congenital hypothyroidism. Thyroid ultrasound shows normal gland in situ. The gland is normal, still patient is having congenital hypothyroidism. It means there must be some problem with uptake. Radio iodine uptake scan shows no uptake. There is no uptake. It means what's the problem? Gland is normal, but there is defective iodine uptake. Correct answer is option D. There is no iodine deficiency. Thyroid dishormonogenesis, because if it's because of iodine deficiency, the radioactive iodine uptake should be normal. Absent thyroid gland, no, because thyroid ultrasound is showing that there is normal gland in situ. There is thyroid dishormonogenesis, no. Radioactive iodine uptake is low or no uptake. It means there is defective iodine uptake. Correct answer is option D. Now see the next question. Very easy, very important. See the knot. In this, you can see this is first throw. This is the second throw. In the first throw, you can notice this is one wrap, two wrap. So there are two wraps in the first throw and there is single wrap in the second throw. Typically, it's surgeon's knot, right? There is one wrap or single wrap in each throw. That is Granny's knot and reef knot. In both, there is single wrap, but in Granny's knot, crossing doesn't occur. In reef knot, crossing occur. How to identify? See the square knot. This is also known as reef knot. Easiest way to identify. In this case, there is one wrap in first throw, one wrap or single wrap in second throw. And in this case, crossing occurs. That's why the ends are together. आप देख सकते हैं ये दोनों red end. These are together. Ends are together. Here blue ends are together. If you see this Granny's knot, here also there is single wrap in each throw, but crossing doesn't occur here. One is above, one is below. Can you see this? In square knot, both ends are either above or either below. Here you can see this red one, 1 and 2. Number 1 is below blue. Number 2 is above blue. This is 3 and 4. 3 is above this red and 4 is below this red. So ends are not together. Ends, these are not together. And when two people are not together, yes, they are not strong. It's not together. Here ends are together. So can you tell me which one is stable knot? Square knot. It's a stable knot. Granny's knot, also known as pseudo square knot. This is also known as pseudo square knot, and this one is unstable knot. Unstable. And this was asked in the NEET PG 2025. You saw the question. There are two wraps in the first throw and there is single wrap in the second throw. Crossing occurs in each throw. So surgeon's knot. We are expecting one question out of it. Next, see this picture. This is carotid angiography. What you can see, there is splaying of carotid because there is a tumor here. And if you can see the splaying of carotid, it is known as Liar sign. What's the name? Liar. So splaying of carotid, name of this sign is Liar sign. What is the cause here? Patient is having carotid body tumor, also known as chemodectoma. So name chemodectoma or carotid body tumor. Read it. There is pulsatile mass. Digital angiography image is shown non-filling on carotid compression, but refilling on releasing the pressure. It means it is arising from carotid. Pulsatile mass means it's arterial swelling and vascular swellings are compressible. What is the diagnosis? It's not the aneurysm. Aneurysm is dilatation. Here what happens? There is splaying of carotid. So there is mass between the carotid, internal and external carotid. There is a mass. This is carotid body tumor. It's not AV fistula. It's not hemangioma. You want to see the tumor. This is the tumor. This is the tumor. And can you see the location of tumor? It is between internal and external carotid. There is splaying, and this splaying of carotid, what's the name of this sign? Liar sign. Lyre is actually a musical instrument जो इंडिया में नहीं बजाया जाता. This is lyre sign. Lyre sign. What's the name? Carotid body tumor, also known as chemodectoma. So name, this is carotid body tumor, also known as chemodectoma. Read this question. This question is based on Kurwai's law. 65 years old man having progressive painless jaundice. He is having itching or pruritus, anorexia and weight loss. All these findings are suggestive of malignancy. Age findings you can see, and there is palpable non-tender gallbladder. On examination, what is the most likely diagnosis? So in this case, see, it's malignancy. And if gallbladder is palpable, this is Kurwai's law. In a case of obstructive jaundice, gallbladder is palpable because of periampullary carcinoma. What do you mean by this? You can see this is liver. You can see this is gallbladder. This is bile duct. This is duodenum. Where is the malignancy? It's periampullary carcinoma, means within 2 cm of ampulla. And what are those malignancies included? Ampullary carcinoma, carcinoma head of pancreas, distal cholangio and duodenal. Then gallbladder will be palpable. In gallbladder carcinoma, yes, it's not the gallbladder, there is a mass inside the gallbladder. And jaundice is not that common. It's not HCC, gallbladder is not palpable. In gallstone, gallbladder is not palpable because it is fibrosed or contracted. Correct answer is carcinoma head of pancreas. So this is Kurwai's law. In a case of obstructive jaundice, gallbladder is palpable because of periampullary carcinoma. Correct answer is option D. You can see the next one. Very easy. You can see this suture. What's the name? Can you see? You can see PDS. This is polydioxanone. What kind of suture is this? Polydioxanone. The polydioxanone, it's monofilament and it is absorbable suture. You know it's PDS. What kind of suture? Absorbable. This is absorbable. In how many days it is absorbed? 180 days. What kind of suture? This is monofilament. It's monofilament. Mono. So it's absorbable. It's monofilament. Correct answer is option B. So here correct answer is option B. Now you can see the next one. A 3-year-old child was brought to the OPD with complaints of dysuria. Another problem, ballooning of micturition. An examination is shown below. Can you see this? In this picture, you can see that here, the prepuce cannot be retracted. Can you see? The prepuce cannot be retracted over glans penis. There is ballooning. So this is actually phimosis. So this is what? This is phimosis. It's not BXO. What is BXO? Balanitis xerotica obliterans. What happens here? There is obliteration. There is inflammation of glands and there is dry looking skin. So this is BXO, it's a risk factor for carcinoma penis. It's not recurrent balanoposthitis, not the recurrent UTI. Correct answer is option B. Now you can see the next question. Based on given image, which type of injury is shown according to Bismuth-Strasberg classification? Now see, this is liver. Okay, you can see this is gallbladder, right? Cholecystectomy was done. So in this picture, you can notice that here the leak is from cystic duct stump. Can you see this? And this is subvesical duct of Flushka, small duct. So there is leak from cystic duct stump or there is leak from subvesical duct of Flushka and this is type A. Most common type of Strasberg classification, it is type A. What is type A? Cystic duct stump leak or leak from subvesical duct of Flushka. I am telling you 100% chances are there in upcoming exam you are going to find minimum one question related to bile duct injury or the stricture classification. Now see this classification, what's the name? This is known as Strasberg classification. So this is Strasberg. This is Strasberg classification. Strasberg classification of laparoscopic bile duct injuries. What happens? You can see in type A, here you can notice that there is cystic duct stump leak or leak from subvesical duct of Flushka. You can see type B. What happens in type B? There is ligation or occlusion of aberrant right sectoral duct. This is aberrant right sectoral duct. And type C, you can notice there is transaction without occlusion of aberrant right sectoral duct. What is type D? You can see the lateral injury of common hepatic duct. So I am repeating, what is type A? You can see the type A. We discussed type A, that is cystic duct stump leak. Or there was leak from subvesical duct of Flushka. Remember, subvesical duct of Flushka. So there was leak from subvesical duct of Flushka. After that, transaction or occlusion of aberrant right sectoral duct. That's type B. And what happens in type C? There is transaction without occlusion. इसका मतलब type B में leak नहीं होगा, type C में leak होगा. In type B, no leak. In type C, there is leak. Type D, lateral injury of common hepatic duct. Type E, it's E1 to E5 bismuth classification. that is E1 to E5 bismuth classification. Any classification which starts from 1, 2, 3, 4, 5, the most common type is 1. And if it starts from A, B, C, D, E, the most common type is A. So what is the most common type here? In Strasbourg classification, type A. मैं बता रहा हूँ 100% there will be one question related to this. So see here, this was Strasbourg, this is bismuth classification. In this case, you can see the common hepatic duct stump more than 2, type 1, less than 2, type 2, hilar stricture with intact confluence, type 3, hilar stricture with destroyed confluence, type 5. So type 2, it is less than 2 centimeter. Type 3, hilar stricture with intact confluence. There is intact confluence, and remember, what is type 4? Hilar stricture with destroyed confluence. There is destroyed confluence, and whenever there is stricture involving aberrant right sectoral duct, you can see aberrant right sectoral duct with or without stricture of common hepatic duct, with or without stricture of common hepatic duct, that is type 5. So that was Strasbourg, this is bismuth, and whenever vascular injury is also included, that is Stewart way classification. So these are important classifications. Now see the next question, easiest question. What you can see in this picture, in this image, you can notice that there is dural tail. So one of the easiest and most commonly asked question, this is dural tail, and this dural tail sign is seen in meningioma. So you can see the picture, meningioma, read the question. 30 years old male having recurrent headache and nausea, MRI is given below, meningioma. Meningioma, there is dural tail sign. Now see the next question, easiest question. This patient is having evidence of varicosity. Patient is having varicose vein. Can you see this? Now read the question. If you see the question, 56 years old male is having this pathology. What's the pathology? Varicose vein. So patient is having varicose vein. Clear? Which of the following is correct? Sclerotherapy is best treatment? No. What is the best treatment? Tell me. Endothermal ablation. So we go for radio frequency ablation or we go for endovenous laser ablation. So it's the endothermal ablation. Next, lipodermatosclerosis or eczema can occur. Correct. Telangiectasia is rare? No, it's not rare, it's common. No possibility of venous ulcer? No, because these patients are having chronic ambulatory venous hypertension. There is possibility of venous ulcer. So what's the correct answer? The correct answer is option B. See, first in the breast chapter, what we are expecting? We can expect one question from nipple discharge, duct papilloma. Yes, treatment is microductectomy, and if patient is having ductictasia, Hadfield's operation. Typical question. Breast cancer is most important. 100% chances are there you are going to get the question related to risk factor, clinical features, investigations, staging and management. Most of the questions will be in relation to clinical features, staging and management, as well as prognosis. You can see how many times it was asked in last 5 years. 100% chances are there you will be getting one question related to breast cancer. Okay, now see the next one. Cystosarcoma phyllodes, there is image based question. Leaf-like appearance, affected breast is massively enlarged. What is the question related to inflammatory breast cancer? Yes, they ask you T4D. T4D, image based question. Breast abscess, lactating female will be there, high grade fever will be there, chills with rigor, presentation, and they will ask you the organism, Staph aureus, they will ask you the management, incision and drainage, and we give antibiotics. Sometimes they ask fibroadenoma. Which question is expected? Cystosarcoma, inflammatory breast cancer, or breast abscess. Okay, next, in thyroid, which question we are expecting? In thyroid, we are expecting thyroglossal cyst. So what happens? Special feature, it moves up on protrusion of tongue. Image based question, or they ask you cyst trunk operation. 100% chances are there. Thyroglossal cyst we are expecting. Sometimes they ask solitary thyroid nodule, investigation of choice, management. 100% chances are there you will get Hashimoto's and Graves. Hashimoto's thyroiditis, Graves, anti-TPO, LATS, presentation, management. Next, carcinoma thyroid, 100% chances are there that you are going to get at least papillary carcinoma, orphan any eye nuclei, that integrated question with pathology, or sometimes follicular or anaplastic. In follicular, metastasis occurs to flat bone, mainly thoracic vertebra, that is the question. And in medullary carcinoma thyroid, there is amyloid, stroma, history of diarrhea, calcitonin. These questions are expected. And 100% chances are there you will get carcinoma thyroid, complications of thyroidectomy. 3 questions I'm telling you. First question is most commonly injured nerve, external branch of superior laryngeal. It leads to, yes, loss of pitch, so patient cannot sing in high pitch. दूसरा है recurrent laryngeal nerve, patient will be having hoarseness of voice. Cervical sympathetic trunk, what happens, patient will be having Horner syndrome. और parathyroid का इंजरी होने की वजह से vascular infarction, signs and symptoms of hypocalcemia like tetany, carpopedal spasm, Vostek sign, all these questions. So 100% chances are there. These two will be asked. Next, in parathyroid and adrenal, what kind of question is expected? MEN syndrome, MEN 1, 2, 3, 4. In MEN 1, there is association with what? Pancreatic neuroendocrine tumor, gastrinoma, insulinoma. So that question. Hyperparathyroidism manifestation is expected. Parathyroid adenoma localization, that cysta-MIB scan, that is expected. And 100% chances are there you will get a question related to pheochromocytoma. Diagnosis, management, phenoxybenzamine and surgical management. Neuroblastoma is also expected. Next, liver. In liver, mainly we are expecting the question related to liver abscess and hydrated cyst, Gharbee's classification, sometimes liver tumor, mainly HCC, clinical features, diagnosis and management. Portal hypertension, most important is varicose bleeding. There will be image-based questions showing the varices, or they will ask the question related to management. Sometimes they ask Sengsteken-Blakemore tube, portosystemic shunt. We are expecting one question in relation to MELD score. Sometimes PELD and CTP scores are asked. MELD score, that is model for end-stage liver disease. Next, in gallbladder, we are expecting questions related to gallstones, management of complications, cholecystitis, strawberry gallbladder, gallbladder polyp. ज़्यादातर चांस क्या है आने का? Yes, usually we are getting image-based question related to strawberry gallbladder and carcinoma gallbladder. Risk factors, staging, management. Next, 100% chances are there you will get at least 2 questions from bile duct. One related to injury, one related to complications. Choledochal cyst is expected. CBD stone is also expected. Mostly we are expecting one question related to cholangitis. What they ask, Charcot striated, Reynolds pentad. 100% chances are there you will get one question related to bile duct injury or stricture classification like Strasbourg and Bismuth. Next, biliary atresia can be asked. Primary biliary cirrhosis, primary sclerosing cholangitis, these are asked frequently for the last 5 years. You can see it was asked in NEET PG 2025, 23, 2020 and INI-CET November 2025. Cholangiocarcinoma, which topic is hot, they ask the risk factors. Next, in pancreas, acute and chronic pancreatitis, clinical features, diagnosis, management, complications, 100% chances are there you will get at least one. Then Ranson's, Bishop, Apache 2, Q-SOFA. These two are important. Bishop and Q-SOFA. There is another one which we are expecting, which is included in Bishop, that is SIRS. Pseudocyst image-based question can be asked, and one question is expected out of serous cystic neoplasm, mucinous cystic neoplasm, IPMN. Next, carcinoma pancreas, 100% chances are there. There will be at least one question related to management, diagnosis or radiological signs. Neuroendocrine tumors of pancreas, 100% chances are there. At least one question. Most important is gastrinoma or insulinoma. So this was hepatobiliary pancreatic tract. In esophagus, 100% chances are there you are going to get congenital diaphragmatic hernia, either Moregagni. Mainly you are getting one question related to Bok-Dalek in which X-ray is given. Then GERD, Barrett's esophagus, motility disorder, 100% chances are there you will get this question. Of achalasia cardia, bird beak, pencil tip, rat tail appearance or diffuse esophageal spasm, corkscrew appearance. Another topic, Zenker's diverticulum, image-based question is expected or they ask the management. We can get one question from carcinoma esophagus, Boerhaave syndrome, and 100% chances are there esophageal foreign body, that coin question where the coin is in the esophagus. Next, in stomach, peptic ulcer, modified Johnson's classification, complications. Complication में आपको बता दूं, especially the complications related to gastrectomy. विच वाइटामिन डेफिशिएंसी, जिसमें बॉडी में सेंसेशन होना शुरू हो जाती है, लोअर लिम्ब वीकनेस होना शुरू हो जाता है, क्या? विटामिन B12 डेफिशिएंसी, मेगालोब्लास्टिक एनीमिया. डंपिंग सिंड्रोम वी आर एक्सपेक्टिंग. अपर GI ब्लीडिंग वी आर एक्सपेक्टिंग वन क्वेश्चन. Mallory-Weiss syndrome we are expecting. Next, in carcinoma stomach we are expecting the questions related to classification, Lawrence and Borman's classification. ठीक है. Next, GIST, 3 tumors I'm telling you. GIST, carcinoid tumor, pheochromocytoma. Every year there is at least one question from these in one exam. 100% chances are there you will get IHPS. Infantile hypertrophic pyloric stenosis, mainly they ask you the dyselectrolytemia, diagnostic features and management. 100% chances are there you are going to get one question related to complications of gastrectomy. What is the most common complication? Iron deficiency anemia, metabolic complication. And if more than 50% of stomach is removed, patient is going to develop what? Megaloblastic anemia. Okay. Now see, peritoneum, you can get spontaneous bacterial peritonitis, but high chances are there you will get one free gas under right dome of diaphragm, perforation peritonitis. They will ask you the management. Next, mesenteric cyst, 100% chances are there we are getting this question. Mesenteric cyst, Tiloxtride, treatment of choice. In intestinal obstruction, 100% chances are there you are going to get at least one question related to small bowel obstruction, X-ray features, intussusception, the signs, claw sign, coiled spring sign, target sign, pseudo kidney sign. 100% chances are there you are going to get at least one question related to volvulus, coffee bean, kidney bean, bird beak appearance. Okay, so these are image based questions. Next, in small intestine, we are going to get one question from Meckel's diverticulum, usually image-based question, or what kind of ectopic mucosa is there, rule of 2, management. GI tuberculosis, very important, we are expecting barium meal follow through image-based question. Carcinoid tumor, 100% chances are there, you will get at least one question. Large intestine, Hirschsprung's disease, they discuss the scenario, you have to go for rectal biopsy, there is lack of ganglion cells, so there is one question. Colonic diverticulosis, image-based question, sawtooth appearance. Colorectal polyposis, 100%, there will be one question from colorectal polyposis from Hirschsprung's disease. Peutz-Jeghers, there will be hypermelanotic macules. Patient is having recurrent intussusception. What kind of polyp? Polyp is having, tell me, arborization, pseudo-invasion, Christmas tree pattern, and LKB1, STK11, these mutations are asked. We are expecting one question out of it. Next, FAP, HNPCC, at least one question is expected. Gardner Center COTS, carcinoma colon, risk factors, sometimes staging. This is expected. In ileostomy and colostomy, mainly they are asking the complications of ileostomy colostomy. Inflammatory bowel disease, ज़्यादा chance है you are going to get at least one question related to Crohn's, ulcerative colitis, and sometimes you have to differentiate which features are seen in Crohn's, which features are seen in ulcerative colitis. Next, appendix is very important. Either there will be one question from appendicitis or this score, Mantrel score or Alvarado score, or incisions of appendectomy, complications, or Ochsner's-Sherin regime. Next, in rectum and anal canal, there will be at least one question from hemorrhoid or rectal prolapse, fissure or fistula, at least one from these. Nowadays, they are asking the type of rectopexy, abdominal and perineal names. You might get a question related to pilonidal sinus. Out of carcinoma rectum and anal canal, you will get at least one question. Hernia and abdominal wall, chances are there that you will get one question related to inguinal hernia, femoral hernia, presentation, complications, management. ज़्यादा chance है, 100% chances are there you are going to get the question related to boundaries of triangle of doom, triangle of pain, nerves injured, right? Strangulated hernia, and another question which we are expecting, omphalocele gastroschisis. Next, in spleen, rarely one question is asked, and if question will be asked, it is related to indications of splenectomy, complications, mainly OPSI, and sometimes they are asking the splenic tumors. So this was GIT. Now see the urology. 100% chances are there. There will be one question related to renal stone, like crystal, risk factor, presentation, management. Genitourinary tuberculosis, 100% chances are there. We are going to get at least one question related to diagnosis, radiological science, one question related to tumor, angiomyolipoma, image-based question in which you are going to see those rounded lesions, multiple lesions having fat, which is having minus 20 Hounsfield unit, relatively black appearance in the kidney. RCC, they can ask clinical features, diagnosis, management. Cannonball secondaries, Wilms tumor, they can ask. AD-PKD, they can ask PUJ obstruction, horseshoe kidney. Expected 100% chances are there that adder head or cobra head appearance will be asked. Duplication of ureter is expected, especially the diagnosis and VUR. Next, in urinary bladder, mostly they are asking the image-based question related to ectopia vesicae. Bladder stone, they can ask. Bladder rupture will be asked. Intraperitoneal, extraperitoneal, flame sign, pear sign, teardrop bladder, these questions. Management. And carcinoma bladder, nowadays they are asking clinical features. Mainly they are asking risk factors. Management, chemotherapy regimen, MVAC. And for intravesical chemotherapy, what you give? Mainly we are giving, most effective is BCG. In prostate, 100% chances are there. Either you will get one question related to BPH or CA prostate. What question is expected in BPH? Mainly TURP, its complication, TUR syndrome, irrigation के लिए कौन सा fluid use करते हैं? With monopolar cautery, it is 1.5% glycine. With bipolar cautery, we are using normal saline. CA prostate, they can ask you the management and the diagnosis. Next, urethra penis, hypospadias, the sequence of repair is asked. Posterior urethral valve, keyhole sign or MCU picture is asked. Phimosis, paraphimosis, image-based question is asked. Urethral injury, 100% chances are there. There will be one question related to posterior urethral injury or anterior urethral injury, diagnosis, management. Carcinoma penis can be asked, the management specially. In testis and scrotum, we are expecting undescended testis. Mainly, we are expecting this testicular torsion, 100% chances are there. There will be one question. Varicocele, hydrocele can be asked. Funous gangrene, 100% chances are there. You will get at least one question. Testicular tumor, high chances are there. You will get at least one question. क्या question expected है? Integrated question between surgery and pathology. The diagnosis is seminoma, that classical picture. So this was urology. Now see the CTVS. In arterial disorders, we are expecting peripheral arterial occlusion, Burgess disease, mainly ABPI. What is critical limb ischemia? They ask you lumbar sympathectomy, AV fistula. Aneurysm, they ask you the cutoff diameter, 5.5 in abdominal aortic aneurysm. Vascular graft, especially CABG, they are going to ask you. Okay. Venous disorders, DVT, very, very important. Pulmonary embolism, very important. In varicose vein, diagnosis, and especially they will ask CEAP classification. Next, lymphatic system, lymphedema can be asked. Thorax, lung, at least one question will be there. Mediastinal mass, which one is most common? Anterior, middle, posterior mediastinal mass. Pneumothorax, hemothorax, 100% chances will be there. Are there that there will be one question? 200% chances are there that you are going to get tension pneumothorax. So, tension pneumothorax will be asked. Clinical features, diagnosis, management, 200% questions, chances are there. Pulmonary embolism or fat embolism will be asked. मैं आपको बता रहा हूँ, I'm telling you. Yes, carcinoma lung, 100% chances are there. Type, especially questions are asked in relation to small cell cancer, small cell lung cancer and squamous cell carcinoma. Trachea, esophagus, foreign body, we discussed that coin in the esophagus. Next, burns, at least one question will be there related to burn classification, burn size, resuscitation or Parkland formula. Plastic surgery, skin lesions, there will be a question related to skin grafting, marginal ulcer, skin malignancies, at least one question will be there. We are expecting basal cell carcinoma. Cox peculiar tumor, Pott's puffy tumor, this can be asked. Angular dermoid is being asked for the last 2-3 years continuously, for which surgical excision is done. इसका image based question आता है, image based question is asked. Next, wound healing, they ask you classification of surgical wound, degloving injury, 100% chances are there. There will be वन क्वेश्चन रिलेटेड टू कंपार्टमेंट सिंड्रोम। आप लोग सोच रहे होंगे कि सर तो सारे क्वेश्चन में आप 100% बोल रहे हैं। वाई आई एम टेलिंग यू, सी NEET PG 2025, INI-CET 2021, November 2021, FMG 2021, August 2020. So in all exams, these topics are asked. Pressure ulcer, see, why? High chances are there you will get it. NEET PG 24, 22, INI-CET 24, 22, 21, FMG 21. Negative pressure wound therapy, we are expecting. Hypertrophic scar keloid, we are expecting. Okay. Next, Berry aneurysm, मैं आपको बता दूं 200% chances are there. EDH and STH, highlight it. 200% chances are there, you will get it. Third topic, diffuse axonal injury. Sometimes they ask worst headache of my life, subarachnoid hemorrhage. Skull base fracture can be asked. In brain tumor, meningioma, dural tail, and glioblastoma multiforme, butterfly tumor. These are asked. Next, oral cavity, they ask erythroplakia, leukoplakia, speckled erythroplakia. Leuko and erythroplakia, image based question is expected. Diagnosis and management is expected. Diagnosis कहाँ से करेंगे? Wedge biopsy, we discussed. CA lip and tongue, especially we are expecting one question related to carcinoma lip. Next, salivary gland, mainly they are asking the tumors, types, management. Parotidectomy classification, this one, Fraze syndrome. High chances are there, almost 100% chances are there. We are expecting this question. We are going to get this question. Next, pleomorphic adenoma, Warden's tumor or adenoid cystic carcinoma. One question out of it. Ranula or silolithiasis, you will get at least one question. Okay. Neck, in neck, carotid body tumor or cystic hygroma. This is expected. One question related to RND, MRND, lymph node levels. Cleft lip, cleft palate, timing of repair. Soft tissue is repaired at 6 months, hard at 15 to 18. So lip 6 months, soft palate 6 months, hard palate 15 to 18 months. In oncology, sentinel lymph node biopsy, they ask you that typical question, most commonly injured nerve, intercostobrachial nerve, most common complication, tattooing. Oncological emergency, tumor lysis syndrome and superior vena cava syndrome. This is expected. Soft tissue sarcoma, they can ask one question. Radiosensitivity of organs, sometimes they ask the question. Pediatric surgery, one question is expected. Sacrococcygeal teratoma, sometimes tracheoesophageal fistula. Trauma, 100% chances are there. There will be one question related to triage, ATLS protocol, primary survey. Airway, breathing, circulation, disability, 100% chances are there. ATLS, GCS, this will be asked. They might ask RTS, revised trauma score, trauma and injury severity score, mangled extremity severity score. Next, 100% chances are there. There will be one question related to blunt trauma, investigations, fast, DPL management, damage control surgery, at least one question, flail chest, definition, management. Transplantation, you might get one question, not necessary. Sometimes they don't ask this topic, especially the type of graft, graft rejection, liver transplantation. Robotic, laparoscopic, bariatric surgery, they give image-based question. Veris needle, what are the gases used? And nowadays they are asking bariatric surgery frequently. What we are going to get? Roux-en-Y, gastric bypass, biliopancreatic diversion or duodenal switch. This is expected. Sutures, 100% chances are there. You are going to get image-based question. Let me tell you, catgut, proline, monocryl, polydioxanone, vicryl. These are the questions. They are going to ask you the knots and sutures. Mattress sutures, interrupted suture, square knot, Granny's knot, surgeon's knot. We are expecting this. Next, sterilization and infection, it's common topic. Hospital acquired infection can be asked. Wound grading, Southampton wound grading or asepsis score can be asked. SIRS, almost 100% chances are there. You are going to get it. Cellulitis, erysipelas can be asked. Necrotizing fasciitis, gas gangrene, you can get a question. Fluid, electrolyte, nutrition, TPN, you will get one question. Refeeding syndrome, most characteristic dyselectrolytemia, hypophosphatemia. I am telling you, this question is trending. High chances are there you are going to get it in exam. Next, shock, mainly they are asking two shocks, hypovolemic and neurogenic, because both of these are caused by trauma, hypovolemic and neurogenic. In hypovolemic, what's the problem? There is hypotension and tachycardia. In neurogenic, there is bradycardia. In hypovolemic, patient is having cold, clammy skin. And in neurogenic shock, because there is loss of sympathetic tone, there is vasodilatation, so warm skin is there. So they ask you ATLS classification of hypovolemic shock, physiological characteristics. You will get cannula, color coding. Mainly they are asking green, that is 18, pink, that is 20, flow rate. Miscellaneous, you can get nasogastric tube, Humby knife, harvesting of skin graft, Foley's catheter, color coding, frostbite, saw sepsis. They will ask 100% chances are there. There will be one question related to complications of blood transfusion. TNM staging at least 5: breast, gallbladder, stomach, colorectal cancer, oral cavity. So these are the topics which we are expecting in upcoming exam. Good luck for the exam.